Hi, thank you for joining me in this discussion on the effect of pregnancy on PBC and what considerations you may have when you're treating a pregnant woman that has PBC. My name is Aparna Goel. I'm an associate professor of medicine at Stanford University, and I happen to take care of a lot of patients that have PBC and other autoimmune liver disease conditions. So I'll first start by saying there is actually very little data on PBC women that become pregnant. And this is mainly because of the population that the disease tends to affect. So as you may know, PBC does predominantly affect women, but usually the women that are affected are ages of 50 to 60 or so. So considering pregnancy tends to be a little bit less likely in that population. There are absolutely instances, though, when women are diagnosed at younger ages, and actually being diagnosed at a younger age tends to portend a worse or a less favorable prognosis. So it is important to take into consideration how you're going to be managing a pregnant woman that has PBC, what special monitoring considerations you need to have, what the safety of your medications might need to be, and any discussions you might need to have with the OB doctor in terms of postpartum monitoring. So we'll first start with an understanding of the effect of pregnancy on primary biliary cholangitis itself. So the sort of, classic hallmark laboratory abnormalities in PBC are cholestatic liver abnormalities. So alkaline phosphatase being elevated or GGT being elevated or a bilirubin value that's elevated. In pregnancy, however, the alkaline phosphatase does tend to rise, and that's because the placenta also produces alkaline phosphatase. So it's not a reliable serum biomarker for monitoring PBC activity. What we tend to rely on a bit more are AST and ALT values, total bilirubin values, and the GGT. So just a reminder that during pregnancy, a woman with PBC is likely to have a rise in the alkaline phosphatase. That doesn't mean the PBC is flaring. It is most likely a production from the placenta, and it is important to take into consideration what the other liver tests are doing. Have they changed? Have they increased? To really understand if the PBC is flaring. Symptoms of PBC. So as you may recall, extrahepatic symptoms of PBC, including pruritus and fatigue, can be quite debilitating for our patients. Pruritus tends to affect close to 80% of our patients living with PBC, ranging from mild to very severe. Pruritus in PBC can worsen, and it typically tends to worsen in the second and third trimester. This may be due to an overlap with intrahepatic cholestasis of pregnancy. So if you are taking care of a woman with PBC and they happen to get pregnant, it may be helpful to actually check serum bile acids during the first trimester so that you have a baseline or an understanding of what the serum bile acids are. And if pruritus does worsen over the course of pregnancy during the second and third trimester, you can sort of trend what has happened to those serum bile acids and if there may be an overlap of intrahepatic cholestasis of pregnancy. Typically, most women that are pregnant with PBC actually remain very, very stable and have healthy deliveries and healthy infants with very safe maternal outcomes. A small minority of women experience biochemical worsening. And when that does happen, that typically actually happens in the postpartum period. So we'll go into a little bit of a discussion on maternal risks. I briefly mentioned that there is a potential increased risk of intrahepatic cholestasis of pregnancy in women that do have PBC, and that can be very hard to distinguish the pruritus from PBC versus intrahepatic cholestasis of pregnancy. But just a reminder that if serum bile acids are elevated, it may increase fetal risk. So it does sort of guide the decision-making with the OB physicians on when you may want to deliver the baby. The other important considerations for maternal considerations are monitoring fat-soluble vitamins. So chronic cholestasis from PBC can reduce fat-soluble vitamins, so vitamins A, D, E, and K. Most women that are pregnant are taking prenatal vitamins, but it is important to also monitor for these fat-soluble vitamins and to supplement during the course of the pregnancy if needed. Vitamin K evaluation or monitoring of the INR is crucial to prevent bleeding, and especially any postpartum hemorrhage that women may be at risk for. So really ensuring that vitamin K levels are adequate and that the INRs are normal. And then the other important maternal consideration is the stage of liver disease that the person has during the time of pregnancy. So some people, especially younger people that present with PBC, may have more advanced disease or may progress more rapidly. And if cirrhosis or portal hypertension are already present before pregnancy, it is incredibly important to monitor for worsening portal hypertension. So we know that during pregnancy, that portal hypertension can worsen, increasing the risk of variceal bleeding, ascites, and preterm delivery. So if prior to pregnancy, even, it's important to have that endoscopy to evaluate for varices and to treat them appropriately. And if an endoscopy hasn't been done prior to pregnancy, really thinking about that before the second trimester is incredibly important. So in someone that has cirrhosis or portal hypertension, very close monitoring for worsening of portal hypertension and especially bleeding is crucial. Now, in terms of fetal considerations, there is a very slightly increased risk of preterm birth or low birth weight in infants that are delivered to women that have PBC. With good control and close monitoring, though, most pregnancies result in healthy infants, and it's quite rare to see complications in infants. The medications that we use to treat PBC. So first-line medication, as you know, is ursodeoxycholic acid. This is considered safe in pregnancy, and it's considered safe in breastfeeding. It's a medication that we use frequently to also treat the intrahepatic cholestasis of pregnancy. It should be continued during pregnancy. And oftentimes, if there is a worsening of pruritus, it often actually improves the pruritus if that pruritus is due to the intrahepatic cholestasis of pregnancy. So ursodeoxycholic acid should be continued during pregnancy. Ensure the adequate weight-based dose from the pre-pregnancy weight of 13 to 15 milligrams per kilogram per day. The other second-line medications that are approved, so seladelpar and elafibranor. In the studies with seladelpar in animal studies, there hasn't been any known teratogenic effect, but there's really insufficient data to understand the safety in pregnancy. Elafibranor, it is not recommended to continue in pregnancy as there is potential fetal harm. And then if you're using other medications to treat itch, so if you're using cholestyramine to manage the pruritus during pregnancy, it is safe to continue that, but incredibly important to just monitor for those fat-soluble vitamins as it can potentially worsen vitamin K deficiency. So just ensuring, again, that the adequate vitamin monitoring is occurring. So what do we do to monitor our pregnant women with PBC? At the very least, seeing them every trimester with laboratory values. So your liver function markers, your bilirubin, your INR, your liver enzymes, including your AST, ALT, alkaline phosphatase, and monitoring for the vitamins, as I mentioned, vitamins A, D, E, and K, and then ensuring that you have a sense of the serum bile acids. The OB physicians that you're collaborating with will most likely be getting fetal ultrasounds during the third trimester. And then just a reminder that when the serum bile acids do become elevated, especially if they're over 40 micromoles per liter, the management in terms of timing of delivery should really follow some of the intrahepatic cholestasis of pregnancy protocols in consideration for earlier delivery. And then lastly, in terms of postpartum management and the mode of delivery. So the mode of delivery should not be impacted by having PBC itself. Your OB physician should decide the safest mode of delivery based on the any other characteristics or factors that could influence the type of delivery. Postpartum flares can occur. So repeat liver tests are recommended about 6 to 12 weeks after delivery, and it may be needed to consider the addition of second-line therapy or sort of ensuring compliance with ursodiol, ensuring that you're using the appropriate weight-based dosing of ursodiol as well. And then just a reminder that UDCA is compatible with breastfeeding, so can absolutely be continued. So in summary, not a lot of data to help us understand how to manage women with PBC that do become pregnant, but in general, both the maternal and the fetal outcomes are great. It is important to continue medications, to monitor and to manage symptoms, and to ensure that you have a good monitoring plan and communication with your OB doctors in terms of the postpartum management. So thank you very much for listening to this short webinar on managing PBC during pregnancy.